Hello, my name is Allan Deutsch, and today we're going to be talking about anterior endodontics for the general practitioner. And I measure all new techniques and materials against this standard. If the rate is the same, is it easier, cheaper, faster, or more predictable? Because I thought our success rate would increase just as long as I practice. In other words, the more years in practice, the better the success would get. But it didn't quite work like that. The red line represented what I thought would happen. The reality was it came in discrete little bunches, and it came every time we changed techniques in our office. This is a terrific little study. It shows the success evaluation of 2,000 endodontically treated teeth. Try to do the treatment when the tooth is still vital. Now, conventional treatment versus non-surgical retreatment. What we found here is that on average, around the world, root canal is about 92% successful. If you retreat it, it's about 88% successful. If the retreatment doesn't work, if you do an apico, it's roughly 75%. If you're using the microscope, the percentage does go up. If you do an implant, it's roughly 92% successful. And what will happen, that patient will have a tremendous amount of postoperative pain. You'll get a telephone call late at night, and the patient will tell you, as soon as the anesthesia wore off, it started to hurt me. That's usually pathognomonic indication of over-instrumentation. Length of treatment for 80% of the endodontic cases that come into your office. And when I say 80%, I'm not talking about the calcified canals or the canals you can't see or the ones with extra roots. I'm talking about straightforward endodontic cases. So here you can see a little movie of the mirror, and the bottom part is the rhodium, which is a little darker on the split mirror, and the top part is tantalum pentoxide, which is a reflective coating. It increases the reflection dramatically, and the anatomic apex. In this actual picture of a tooth, your filling material should be any place between, here's a picture of the anatomic apex and the radiographic apex. The faster you go with rotary, the quicker the breakage will occur, and the angle of curvature of the canal. The more the canal is curved, the quicker the instrument will break. Consequently, you're not going in a circle, so you eliminate cyclic fatigue, and which is a big, big contributor of breakage. Now, the cyclic motion also happens in a 30-degree plane. That will let you open up the sharp bend and start to straighten it out pretty easily. The bottom of this photograph is a piezo-reamer. The difference, you don't want to keep washing out the canal with hypochlorite. If it goes past the apex, you can wind up with something like this. An interesting thing happens. It doesn't go into the periapical area. It actually tends to go into the lateral canals. And that's because of the design of the spiral. It will tend to push the cement laterally against the walls and not apically out of the tooth. You can readily see the lower apical and lateral canal that was filled with the sealer. I hope you enjoyed this presentation today. We took you through a lot of endodontics, from access openings to filling canals to irrigation. And I'm sure if you follow some of these hints and benefits, you'll enjoy a higher success rate in your anterior endodontics.